Cara, our listeners are in for such a treat with this episode.
I mean, this is one episode where I wasn't expecting to laugh quite as much as we laugh, especially on the heels of words like endometriosis and colposcopy. But we did. We went there.
Dr. Karen Tang is such a joy. She is hilarious. I mean, she's a board certified gynecologist and a minimally invasive gynecologic surgeon and an internationally recognized leader in reproductive health. So she's not just hilarious, she's deeply qualified and knowledgeable. But she has so much to offer in educating people because she's fun and open-minded and relatable, as is her new book.
This episode talks about It's Not Hysteria. I'm holding it up for the YouTube viewers right now. It's Not Hysteria, which is an incredible read, frankly. And it's a read that people should just have on their shelves as a reference resource. It's really meant to be flipped to with specific questions. But one of the things I love about the way she approaches gynecologic care is she talks about it from the perspective of all ages. So we talk a lot about tween and teen health in this episode. We also talk a lot about gynecologic health for people in their 30s, 40s, 50s, 60s, because there's a through line to this information. And frankly, her mission is to create a very clear basic understanding, starting with the vocabulary and then getting into the science and then understanding how things have changed. Does this sound familiar to our listeners? It's the same way we approach science. She does it for gynecology, which I'm not saying OBGYN because OB is the pregnancy side of it. So she really does more of the non-pregnancy side in such an incredible way. If you have any questions about any person's gynecologic health, I would say from the tween years all the way through late in life, this is an episode for you.
I mean, you're going to be shocked we said this, but enjoy. Karen, we are so excited to have you here.
I am so excited to be here. I've been looking forward to this for a really long time.
And I did the creepiest thing, which I know Karen will forgive me for, but I went to hear her speak before. We'd already booked the taping, but when I have an opportunity to meet a future or past guest in person, I do it. And she was being like rushed off stage. And I literally like rushed the stage like I was going to go body surf. And
you're
just
like
so
one
I
of the first people. You like I don't say you like push people out of the way, but no, you were like, you ran right up.
I did. They were like,
those out.
There were bodies flying, but I had to leave. I had to make a train, and I was like, I'm gonna take this moment now and say hello, because meeting people in person is so valuable and wonderful. And so, yes.
Oh, that meant so much to me that you came out too. Because we had like, I think exchanged like 2 emails, and I'm like, you came to my event. That means a lot to me. So no, just both of you guys taking on this book at all is great. And then coming to see me in person was even more amazing.
Are you kidding? We are psyched. I mean, this is it's just the right tone. We're going to get into all that. So that was a no-brainer. If I could have just jumped on a plane from LA, I would have been there too.
Cars was having having event envy.
I was. I do.
So let's start from the beginning, which is the title of the book, but really the larger concept. The book is called It's Not Hysteria, but let's ground us in the history of the concept of hysteria and its relationship to the evolution and understanding of women's health.
Isn't that word great? I mean, it really kind of captures it all. And when
it's such a good title.
Yeah, there's a whole lot that gets wrapped up into that one word. I mean, way back in olden times when they literally thought there's something wrong with your uterus, like the word for, hysteria means, of the uterus. Hystra is the word for uterus in Greek. And, in ancient times, they thought that it was literally your uterus was malfunctioning. And then in the 1800s, we got, Freud, and it's all repressed anxieties and all of your crazy woman stuff that is manifesting as your physical physical symptoms. And, today when we say hysteria, you have all of those meanings kind of wrapped up in it, where we say, if you're having too many complaints, you're feeling too many things, and there can't possibly be a medical explanation. It must be just in your mind. It must be you're too anxious, you're over analyzing your body, you're a hypochondriac. So all of that gets tied into this. And, even I mentioned in the very beginning of the book, I hope that medical providers and healthcare workers read the book, because it's not that we're like bad people. It's not that, everyone's setting out to be misogynistic, but we're human beings and we absorb these messages of, history of our culture. If you have a woman who is complaining of, pain, bloating, nausea, vomiting, diarrhea, like migraines, fatigue, all these things. Well, there's not one thing that can explain all of them, but actually lots of, GYN issues can explain all of those, like endometriosis. It's just the lens with which you see it. And if we come to it with this like historical understanding of women's health, you're going to have like this bias when you are in the doctor's office. It's going to be there no matter how well-meaning or, educated like a healthcare professional is. They're going to have some of these in the back of their mind. So, the message of the book was really, and of all my social media, is it's not hysteria. These are real things. They deserve much more attention than we've given them historically. And how do we move on from here? How do we change this?
I will say that even just listening to you speak, but also reading the book, the irony of the one letter difference between the history and hysteria, the power of the I to the Y, is very interesting, because hysteria, I used to describe hysterical laughter often as sort of a joyful, right? And then you stop and you get the history with an I of the history with a Y, and right, I don't use that term anymore.
And it's so gendered. Like,
so gendered.
You don't usually call men hysterical. Yeah. Mm-hmm.
No one calls men hysterical, but literal,
because they're not that funny.
But the etymology of the word is gendered, deeply gendered, right? And then it has become gendered. And so your goal, and the goal of all of your work, is to dispel the mythology, the assumption, the feeling that people with uteruses and people who identify as women should not dismiss their pain, their challenges, their medical needs. And so this episode is really about educating everybody. And to that end, Cara, should we dive in?
Yes, because I want to make that leap that you just made from having a uterus to pain. That's right. There's this, can you walk us through that connection and the sort of the path that so many people have walked down, which is this expectation that they should just live with their pain?
Yeah, I was going to say one of the most common things I probably say in interviews is just because something is common, it's not necessarily normal. And it's become so ingrained in everyone, this expectation that periods are supposed to be really painful. Sex is supposed to be really painful. Menopause is supposed to be horrible, but you're somehow supposed to just accept that and just deal with it. I think so many people, it just blows my mind how often people are told this. Well, that's normal. ... And that's it. There's no like, let's fix this. Like, let's figure out what's going on. It is sort of left at the point of, well, but just everyone has that. So
that's right.
You just have to learn to accept it. And it's been so normalized. Like female pain is just in general, like very normalized. The amount of people who say, well, it's always going to be super duper painful when you have sex, or, especially the first time, that periods are always horrible. Everyone has that. Even if a lot of people do have that, it's not okay. It's not that, you like have to just deal with it. There are things that could be going on, things like endometriosis, fibroids, pelvic floor dysfunction, actual medical conditions. I always say, again, with the gendered thing, if every man was like suffering excruciating agony, like half of, or like a week out of every month, we would investigate that. We would figure out what's going on. We would help to treat it. We wouldn't just be like, whoa, sorry, guys.
I just want to do a side note on Bridgerton for a minute. So we've talked a lot about Bridgerton on this podcast because in the season 1, the
consent,
first sex scene, right, was like within 30 seconds, the character was having an orgasm, first time she ever had sex. I'm watching the newest season of Bridgerton, and it's very interesting how they're rewriting the narrative of first time sex, but it still falls into this funny category that you just described, where the man, Colin, is saying to his partner, Penelope, it might hurt, but only the first time. And I found that Vanessa stopped with her daughter in season 1 and had a moment where she was sort of debunking the myth of what was being presented there. And I actually stopped the show and just had to sit with it for a second, because that is the narrative, right?
Yeah.
That is the narrative.
It's funny. When season 1 came out, I actually did like a whole YouTube episode, like addressing all the issues in it, like the consent and like the ease with which, like she had an orgasm within the first 10 seconds. It
was amazing.
Amazing. We talked about withdrawal. Like there's so many things that
Karen,
that show raises.
I literally paused the show and I looked at my daughter and I was like, what has he done so far? And she was like, he put his penis in her vagina. I said, what does he need to find for her to orgasm? And she was like, her clitoris. And I was like, yes, thank you.
We are a great mom.
How old was your daughter at the time? This is the best part of the story.
14.
Nice. That's great.
Yeah, I think she was 14.
Vanessa for the win.
I love it. That's great. That's it. Yeah. But
so
it's true. I now I need to go back and rewatch this scene from the 3rd season, because actually a couple of people have brought it up to me, and I'm like, I'm going to make a video, because there's so many things that, he's like, oh, it just might hurt for just this first time. It can hurt, for more than that, but does it always hurt the first time? Some people may not. And are there ways to help with the pain? Yes, there are. And what if it keeps on hurting? Again, there's so many things you can kind of dive into. The show is great, but it raises all these good discussion points. So
I would totally share that video far and wide, Karen, when you make it. So let me know.
It's coming.
So speaking of families and conversations and pain, so much of the conditions, and we're going to dive into some specific and common conditions, have a genetic component to them. And you talk about how many people assume that pain is normal because they've seen their siblings in pain, their mothers in pain, their grandmothers in pain, that the family history and the family narrative is yes, we all have this, and this is the way it is in our family, and there we go. So help us understand the genetic component and how we break the cycle of pain while still being part of the larger narrative of being in a family history.
Yeah. So I mentioned in the book, we don't actually know what the genetic component is. And this is the sad fact about so many gynecologic issues. There's just not enough research, so we can't pinpoint yes, this one gene, but they definitely do run in families. So, and that's for several things. Endometriosis, fibroids, very commonly affect many people in a family. So just like you said, it becomes almost this family narrative where everyone, grandmother, mother, sisters, cousins, everyone has had horrible periods. Oftentimes things like fertility issues. So both of those can cause problems with fertility or miscarriage. So they may not say, oh, we have a family history of endometriosis, but very commonly when you ask, they'll be like, yeah, everyone, my mom, somebody had a mystery hysterectomy. They don't know what it was for, but they had to have their uterus removed. And then they, before that, they had trouble getting pregnant. They had miscarriages. So that is very, very suggestive of either endometriosis or fibroids or both. But the problem is then, because nobody has a different frame of reference, they all had the same horrible experiences. They're like, well, just everybody has painful periods, or everybody is soaking through pads or having super heavy bleeding, and that they don't realize, how would you know? Again, because we're so uncomfortable talking about these things, it's not like you're going to have a super in-depth conversation, with your colleagues or your friends about your menstrual flow. So oftentimes the only conversations are the ones that they might have with their mom. So that's their frame of reference. And the problem is then that gets perpetuated to each generation. Well, everybody has painful periods. Everyone has heavy periods. That's just how it is.
Right. And it turns out you all just have the same bleeding disorder.
They all just have the same condition. Exactly.
Why not? Yes.
Yeah.
So Karen, what do you recommend when you talk to patients, or when you're hearing from patients a certain set of symptoms or kind of commonalities for our listeners, what are sort of the 5 things you are interested in when you hear, like you're saying, soaking through pads in an hour or two in a regular period, or excruciating pain where you can't do your normal functioning? Like, give us a list of those things.
Maybe we can start with kids on the front end of puberty, their sort of top 5 list, and then get to the older kids
years.
who might be sexually active. Yeah.
Yeah, absolutely. And that's such an important question, because that's probably one of the more common questions I get is like, how do I know? Like, what's abnormal? What's something I should be seen for? And obviously for the parents listening, what should I be concerned about, if my kids are having these problems? So it's very common, and I tell people with the periods in the beginning for them to be kind of like irregular, a little unpredictable, and a little crampy. But the warning signs are definitely if they are so bad that you're missing school, you can't do sports, you can't, function or just do like the everyday activities that you want to do. The cramp should never be so bad, and the bleeding should not be so bad that you're not able to do daily living. So this is something that we try and educate, like things like school nurses. If you have a student who's just like constantly when they have a period just like has to get sent home, they're like throwing up. Like those are big, big warning signs that, there could be something like endometriosis. It's not always something like, like a pathology, but it is strongly suggestive. A lot of those situations can mean that there's something like endometriosis. Even if there isn't, you don't have to keep on dealing with it. Again, the message of even if it's common, you don't have to keep suffering with it. Can
I add just to that it feels important when you're in an office seeing a patient, when I was in the office seeing a patient, there are some kids, in particular younger kids, who they're either not used to any of this feeling, this physical feeling, and they are calling it out as pain, but it's not. They're just not able to articulate it. Or frankly, there are some who are, in the most non-judgmental of ways, they're sort of taking one lived experience and using it to their benefit to get out of it, right? They want to not be at school. And when they're younger, it might be stomach aches that cause school avoidance. And when they're older, it might be period pains. And there are a lot of adults who don't know how to distinguish like when the pain is actually real. And to those adults, I would just say, walking into a doctor's office, validating the words that the kid is using, I'm in pain, I'm uncomfortable, and letting a healthcare provider say, everything I see here is normal. Everything here is as to be expected. And I think it's okay. And I think this is what you're feeling is in many cases what you need in order to help a kid get over the hump. We're going to talk about endometriosis. This is a critical piece of this conversation because that I think is one of the glaring examples of when the pain gets blown off and everything's fine, right? But for those who are sitting there going, I still don't know when to believe my kid or when to, when is it a real issue? You don't have to figure it out as the adults in their life. In fact, even if you're a healthcare provider like me, I couldn't figure out my own kids' pain a lot of the time because I was wearing the parent hat with them. I wasn't wearing the healthcare provider hat. So I didn't mean to
oh no, that was very helpful.
Another way, but I feel like I don't want people to think they have to
be the one diagnosing it. No. And that's like the whole idea, with the book, I always tell people, and we have this caveat with all media, social media, like we can't diagnose you. We can't tell you, well, that probably is endometriosis. The only thing we can do is get the information so that you can get to your doctor's office and have that conversation. So definitely, like, we always have the caveat, it's not your job to take this information and be like, I've got to, figure out exactly what's going on. But it is important to, take that step, see the doctor, talk it through. And even if it is something like they're trying to skip school because like they're being bullied or something else is going on, they're having a learning disability and they feel really awkward, so it's also very valuable just to kind of have that conversation. Like, you're missing a lot of school, like what's going on. Yeah, exactly. So whatever it is, just having that conversation, knowing to kind of come in and see the doctor is the most important thing. Absolutely. Great point. But yeah, most important is just to take it seriously because, where it gets blown off, the people's pain is dismissed. Like that's the point that we want to try and avoid. And then as they get into, like later teen years, obviously it's different for every teen when they become sexually active, but having that openness of conversation so that, they can get like contraception if they need contraception, sexually transmitted infection testing, anybody who's sexually active, genital contact of any sort. We talk about testing and safe sex. And also things like, we already mentioned like issues of consent. It's not even just a matter of preventing the bad stuff. So we talked about like there's a much focus on bad things, but also like teaching about the good things and how to, be sexually active in a healthy way. Like, what is it, pointing out the clitoris, like pointing out, how do you have a satisfying sexual relationship in, a safe, healthy way. So, but in terms of like kind of warning signs, like things like having the conversation about safety, partner violence, like that sort of thing is actually super important in those kind of teen years. And then obviously, like as you get into, reproductive years, for someone who is thinking about fertility, when is the point that you see a doctor for that? So we always say if you are under 35, you've been trying without success for like over a year. If there's any issues with your periods, like you're missing periods, you're having the painful or heavy periods, go in sooner. But for just plain fertility things, we talk about like 35, 1 full year trying without success. After 35, we shorten to 6 months because, we just want to kind of catch things a little bit earlier. And then obviously like, perimenopause, menopause, so many discussions about this now, which is so important because again, people have kind of historically been told, oh, just deal with it. It's just hot flashes. It's just sweating. But it can be so disruptive. I don't know if any of you guys have started the perimenopause process. I haven't, but it's a mess. Yeah, it's pretty bad. So again, people who are going through
the definition
like, wait a second,
of a hot mess.
It's a hot mess. Like people, when they finally go through it, like, wait a second, this is not just a little sweating. It's terrible. So, again, just knowing that anything that's affecting your quality of life, and for menopause, that's not just the hot flashes and stuff. It can include like genital urinary symptoms, vaginal dryness, pain with sex, UTIs, urgency of your bladder. All of these are things that are signs of possible menopausal issues. And so, yeah, getting in for that care. Punchline after all of that being said, if it's affecting your quality of life, talk to the doctor. You don't have to keep dealing with it.
And we did an episode with Dr. Mary Claire Haver.
Yeah, I love her. Mm-hmm.
And so if people missed that, go back and listen to that. Karen, I want to get into the issue of racial disparities in health outcomes for women because it ties to all the different conditions we're going to talk about. In that, there are higher rates for Black women than Latina women and higher rates for Latina women than white women in the common gynecologic issues that we're going to talk about. And I was just hoping you could spend a minute talking about why is that? And what do we know? What don't we know?
Mm-hmm.
And where are we hoping there's going to be further resources, research, and information on that topic?
Yeah, and that's a huge topic. And obviously for issues, things like maternal mortality, like that is something that people are really, really trying to dig into the reasons why. Because a lot of times, people may say, oh, it's just because of socioeconomic factors. Even when you account for those in research studies, there still remain these differences. It's not just a matter of access to healthcare or, insurance status or income level or education level. The differences remain the same pretty much even when you account for all of those things. So I talk about these a lot, especially in the chapter on fibroids, because, fibroids are most common in Black women. There's so many different things that could be underlying that. So for instance, vitamin D deficiency seems to be a risk factor for fibroids. And obviously, with more pigmented skin, like you might be more likely to have vitamin D deficiency. But there's also the impact of stress, believe it or not. And this is really one of these amazing medical facts that stress is a risk factor for fibroid formation, especially in Black women. So again, even when you account for like all the other like income and blah, 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 like the stress alone can impact that. And it's been shown in many different studies that, even at higher income levels, Black people in general, Black women are subject to more just kind of chronic stressors. And then another thing, which was just in the news and I mentioned in the book, and it's been talked about in recent years, is the impact of exposures, things like chemical hair straighteners. That actually has an increased association with breast cancer, uterine cancer, and fibroids. There are some things like phthalates, which are found in some chemical hair straighteners that are endocrine disruptors and can impact some of these like hormonally mediated things like fibroids and breast and uterine cancer. So there's still like some research to be done. Like we don't exactly know how they are, is it definitely because of endocrine disruption or, what the impact is, but we are seeing these patterns. And in the book, when I was doing research for it, I found like this incredible study, Duke, I think business school, actually showed pictures of different like theoretical candidates and had people judge, how likely they were to offer them an interview, to, to, et cetera, to hire them. And even when they had the same exact CV, but just showed different pictures, Black women with natural hair ranked lower, were less likely to be offered interviews. And so there truly are these like social pressures that then lead to decisions like using a chemical hair straightener, which might then impact your health. And so all of these things are just kind of mixed up together. And this is where you have this, socioeconomic determinants of health. It's not just race, as like some mysterious like thing.
That's right.
We say race is a social construct. It's not like a medical construct. And there are all these things that are actual factors that go into why are there racial differences.
And there's, I would call it a conspiracy against researchers who are trying to figure out what's going on, insofar as the makers of a lot of these products don't have to disclose their ingredients. And it's making it impossible. I mean, if you can not list an ingredient because it's a trade secret and it's what makes your product work, then how are scientists ever supposed to be able to study the impact? It's impossible. And so there are so many layers that you wrote beautifully about layers of racism and how it impacts our understanding of healthcare and medicine. And this feels like another one to me. The whole world of trade secrets.
Yeah, I mean, it's kind of terrifying that they don't have to. We just don't. It's a trade secret.
Right. Yes, it's what makes our product special, and therefore we're not going to tell you what's in it because we're business people. And it's like, but no, we got to. That runs literally. It runs up against public health in the most profound kind of way. I think this is a good place to get into some of the most common gynecologic issues. And we can circle back to some of the race data as we go through. You talked about endometriosis very briefly. I would love for you to be able to describe what it is. And I was dumbfounded when I read that 1 in 10 women have it. I mean, I almost fell over when I read that data.
Oh, I think it's actually much higher. So here's my just, quickly, what is endo and why do we think it's really underdiagnosed? So endometriosis is a condition where tissue that looks very much like the tissue that grows in the cavity of your uterus, that's the tissue that comes out like period blood, grows outside of the uterus instead. And so very commonly it's between like the uterus and the rectum or the walls of the pelvis or in the ovaries in the form of cysts. And the most common symptoms are really terrible pain. So pain with periods, pain with sex, that's kind of the classic story, but also very, very commonly causes bowel issues. So probably one of the most common symptoms are really bad diarrhea, constipation, pain with bowel movements, bloating, nausea, vomiting. So for instance, it's so bad that a lot of people actually go to their primary care pediatrician or a GI doctor before they see a gynecologist. Because again, it's been so normalized to have period pain. We're like, oh, that's just period stuff. But I'm having insane diarrhea all the time. It happens to get worse with my period or during ovulation. But people will get diagnosed as irritable bowel syndrome because all their testing comes back normal. They have a normal colonoscopy, normal CAT scan, but they're having all of these bowel problems. So, if anybody out there, they themselves or their children are having just unexplained terrible bowel symptoms that get worse with your period or worse with ovulation, that is very, very suggestive of endometriosis.
And just to put a finer point on it, just so that those who are trying to connect these dots can connect them more easily. If you have tissue that's hormone sensitive and it's going to grow inside the uterus, the endometrial lining grows in response to hormonal stimulation. That same tissue outside of the uterus grows in response to hormonal stimulation. So if you've got these hormones coursing through your body and the tissue is sitting outside of your intestine, not inside your uterus, and it grows because there's hormone coursing through your body, it will put downward pressure, like literal physical pressure on the intestine. Wherever that tissue happens to be, it grows with hormonal exposure. And then in the cycle of the period, when the hormones shift and the endometrium lining sheds with a period, so too, it shrinks down a little elsewhere, right? Relieving a little of the pressure. So that's why, is that a fair description of why?
It's a lot of inflammation. Yeah, because it's very inflammatory. So just everything right next to it can get like inflamed and irritated. Like your bowel can actually physically swell up. Like the endometriosis is oftentimes very tiny. So the actual physical size of it probably doesn't change, but everything around it can change.
Hand wrapping, but it's not.
It's not like that. Except, usually I tell people it's like taking a pen and drawing like dots, like on the paper. And that's actually why it doesn't show up on imaging studies unless it's really bad. Because oftentimes it's so teeny that like you know, even through an MRI, like will not get picked up. So the problem is, kind of the punchline of why is it so hard to diagnose is because it often doesn't show up on imaging studies. It's too small. And unless it's really severe to the point that's formed masses and like it's growing into the colon or it's making big cysts. But because it can really affect everything, like what can get bigger is, your colon can actually inflate. Like people look like they're pregnant, like they call it endobelly, or literally they look like they're pregnant because their bowel has swollen up so much. Or they get really bad, like, like the constipation, like your muscles seize up as well. So your pelvic muscles cannot work right because of the inflammation. So they have pain with sex, they have constipation, and they have to strain to have bowel movements. So it's really terrible. And it can cause infertility. It can scar your tubes and cause problems getting pregnant, or it can affect the egg quality and cause miscarriages. So it's really quite a terrible disease. And where I was saying is I think it's a lot more common than the 10% that we quote, is that because it's only diagnosed on laparoscopy, you can sort of guess that someone has it based on their story, but we don't know 100% unless we actually look with the camera, we see the spots, we remove them. Pathologist says, yep, that's what it is. Because not everyone with all these symptoms is having surgery. We're probably missing a lot. And here's my fun fact. When Roe v. Wade was repealed and people were coming in en masse for sterilizations, I was doing a ton of tubules, like after Roe, fell. And I will tell you, I saw endometriosis in probably the majority of people, like 2/3 at least. I started putting it on my consent forms for tubal ligation, scalp-injectomy, and excision endometriosis. It's just because, again, it was so normalized for people like, I've just always had bad periods. I was on birth control. It helped. And then I just kind of lived with it.
So let's talk about that, Karen, because there's no blood test for it. There's no genetic markers for it. It's basically like a series of symptoms that you can kind of guess or assume or surmise that somebody has it. Talk about the treatment that even if you're not going in there surgically, that if you surmise that somebody is dealing with this, how do you treat endometriosis?
Yeah. So the first step is usually we try something like hormonal birth control, just because it is very common for people to have, just bad cramps, especially like, teenagers, and then potentially they can just grow out of it. So again, not everybody with like bad periods has endometriosis. So we oftentimes will start with that because, again, it's less invasive than doing surgery on everyone. So oftentimes we start with just birth control. But again, this is the point that endometriosis advocates and experts want to make, is that sometimes people get trapped in that pattern of just trying like birth control. They like many different types. They like try 10 different pills. They try the NuvaRing, they try the IUD, and nothing is working. That's where you're like, okay, we need to do something different. I tell people if, you tried 2 birth controls and it's not working, we got to think about other things, including possible endo. So the actual treatment, like removal of endometriosis, has to be surgical. Like that's the only way to truly get it out of your body. So we do what's called laparoscopic excision of endometriosis. We put a small camera in. We look for any spots of possible endo and we cut it out. And that's the way that we diagnose it. The pathologist says, yep, under the microscope, that's endometrial-like tissue. That's your diagnosis. And it's the treatment is to cut out as much as we can. And it's important because, the birth control and the hormones can kind of like suppress the symptoms. They can make you feel better, lighten your periods, but it's not going to make it go away. So, sometimes if it's still there and it's still growing, you can get the worst issues down the line of like the fertility problems and stuff. So this is where I tell people as a public service, public health thing, don't just kind of accept like, it's good enough. Like if you're like still having pretty bad periods, having to take a ton of ibuprofen just to kind of function, and the birth control like makes it a little bit better, like takes the edge off. Like I tell people like, that's maybe not good enough, see if something else is happening. If you're like, I feel completely fine, then, that's great. But so endometriosis, like I said, probably very underdiagnosed. And the problem is that if there was like an easier diagnostic method, I think we would be a lot better at this. And they're developing some things where, blood test and a test of the tissue inside the uterus, getting a biopsy of that, which is still a little invasive. Where I think that's probably going to be helpful is in places like the UK, where like the wait list is so long. Like it takes them like at least a year to like get in with endometriosis specialists. So sometimes maybe having like more objective data, they can kind of move ahead in the line a little bit. In the US, I think we would still probably say if we have a strong suspicion for endo, we're going to kind of manage it the way we manage it, like get the surgery done, like all of that as soon as we can.
And I want to do a plug for having a relationship with a doctor who has the time and the inclination to take a history. Because Vanessa, one of the things that Karen and I learned in medical school is that the history, the story gets you about 90% of the way to the diagnosis. But even separate from the lab tests and all the scans and everything. Now, our system doesn't necessarily allow for this, which is the root of the problem. Access to care is very difficult. Reimbursement of care has gone down. It's very, very hard right now to find a physician who has the time and bandwidth. But what you're hearing Karen say loud and clear is if someone who's educated, an OBGYN who's educated, has the time to sit and listen and take a history, that will get most of them a long way down the road.
Exactly. I tell people like before I even examine them, I'm like, I have a pretty good sense of what's going on, just hearing the story. And that is so important because just like listening and getting all those details and putting it together and understanding, what common pictures are. Like you said, it's like that's the most important thing. And then what tests to try and order or what treatments to offer. But that's like number one. But you mentioned the whole system is so broken, especially OBGYN. People may wait like months and get like 15 minutes with their doctor. And there's like no way to cover all of this in that much time. And
the data on how little time a doctor listens before they speak is also stunning. I think it's better with female doctors than with male doctors, but because the system is set up the way it is, patients don't necessarily have the ability to tell their story. So there are a lot of pitfalls along this road. And yet there are great and very smart people like Karen out there who can sit and listen and get.
And it's tough. The system wise, I will say, you mentioned reimbursement and people may be like, what does that have to do with it? The ability to keep the practice open and spend a lot of time with patients, it's impossible with endometriosis with like all these complex issues. So for instance, like right now I'm in a private practice. I have an out-of-network practice. I spend an hour with patients for the first visit, and a general OBGYN office, they're seeing 40 to 50 patients a day just to like kind of keep the doors open and pay their staff. The GYN reimbursement is horrible compared with other fields. And that's for primary care, for pediatrics, mental health,
I was going to say, it's almost as bad as pediatrics. It's terrible.
I was about to say, yes.
There's a theme here.
There's a theme, yes.
So it sounds
what do they value and what do they not?
Before people go in for a first appointment, to get some of this stuff down, to do some of the thinking, and you raise a lot of questions. Many of the chapters in the book have questions that a healthcare provider would ask a patient or questions a patient can ask themselves, right? Because sometimes you get in there and you're on the spot and you're like, oh, I don't know. I don't remember. I never asked, or I didn't think about that. So doing some homework ahead of time so you're prepped when you walk into an appointment, I think it's great. Karen, I'd love to talk about fibroids, another super common condition, so much more common than I realized. Also with massive racial disparities, as you talked earlier, related to chronic stress, which is obviously a big issue for folks. Can you first talk about what are fibroids, and then we can talk in more depth about understanding them and managing them?
Yeah, so fibroids are benign tumors, meaning they're masses, but not cancerous. They are made up of muscle cells, like they are growing in the wall of the uterus. So, kind of interesting fact, they're actually all clones of each other. So, all the cells in a fibroid are clones. They're genetically identical. Again, we don't know why they form. There's got to be some sort of genetic component to it because of that, but we just don't know exactly what that is.
Karen.
They're just narcissists. Like it should be more of us.
We're so fabulous. Let's make more and then stick together.
Exactly. Yeah. And they, people can grow one fibroid or they can grow 100 fibroids. So it's also very mysterious kind of, what makes them grow? Like, why do some people grow a lot and others? Black women do tend to have more fibroids, larger fibroids, and oftentimes like more symptomatic fibroids. So the symptoms, we group into kind of 3 different categories. One is pain. They can cause a lot of pain, especially with periods, and they can cause a ton of bleeding. So bleeding issues, like this is probably one of the most like massive bleeding that human beings can experience. Like people can be just hemorrhaging and like getting transfusions and like in the emergency room, just like really outrageous bleeding. And then the third is what we call bulk symptoms, and that they sometimes grow so big, people can look like they're pregnant. It pushes on your bladder and makes you feel like you need to pee all the time. You have constipation because it's blocking your rectum. So they can actually cause just really bad symptoms because they're just so huge sometimes. So part of the problem, we've mentioned a few times about the not knowing exactly what causes them is that we can't prevent them and we can't keep them from growing back once we've, say, removed them. So the treatments for fibroids range from things like, medications to try and control the bleeding, anti-inflammatories for the pain and cramping. But for the actual size of the fibroids, you have to just remove them surgically or destroy them with procedures. But the problem is once you do that, like they could just grow right back. So whenever we talk to someone about their treatment options, unless someone's ready for a hysterectomy where we do the surgery and remove the whole uterus altogether, they can always just grow right back in like a couple of months and a year. So the problem is, with medical things in general, we like to do preventative care. We like to prevent them from returning or having a problem again in the future. The trouble is for a lot of gynecologic things, fibroids, all of these, we don't know how to do that. So it is very discouraging and, especially concerning because it does affect, largely like Black women. Why is it that something is so devastating? We just don't know. Like we can't prevent them. Like we can just chase the problem once they develop. And so it is a justice issue too. I feel like in a lot of ways that these things are like, I say this all the time in videos. If this affected men, like if it's affected white men, made you hemorrhage, go to the ER, like feel like you were bloated and uncomfortable and miserable all the time, could potentially cause infertility. Like we would know what caused it. And we would have every treatment under the sun, like all the research dollars would go towards it, but it's not considered like a real problem for, women's health. It's just women's health. It's just a women problem.
Will you speak a little bit to the age of onset of fibroids? Because I will say as a pediatrician, when I saw heavy bleeding in kids who were starting to menstruate, it was never high on my list. There were a lot of things that were high on my list, but fibroids weren't. But when I would see new moms who had just had a baby, I can't even count how many moms were diagnosed with fibroids either during their pregnancy or right before their pregnancy. So what's the onset?
Yeah. So it's often not seen during teen years. So you're right. Like, if somebody's bleeding really heavily with their first periods, like we're definitely not thinking fibroids. It's possible, but pretty rare. But they do tend to show up kind of in the 20s. That's when we start to see it, and then really, really causing problems in the 30s to 50s. So kind of like the mid to later reproductive years is then people are like, my periods are getting really heavy and they're getting more painful. Like that story makes us think, okay, we should get an ultrasound, look for fibroids. But you're right. Like if you have a teenager who is bleeding really heavily, we'll still get an ultrasound just to kind of check and see. But very often the ultrasounds come back totally fine. So you're right. It's not like a really common, like kind of, pediatric cause. But definitely, yeah. As soon as you're in those like kind of like 20s to 50s, we got to think about it.
So in contrast to endometriosis, fibroids can be seen on imaging.
Yes. Yeah. So that's the one good thing. Yes.
So let's move to PCOS, which is, I guess, Karen, is it safe to say that is I don't want to use the word mysterious. But when we think about something with clusters of symptoms that is very hard to diagnose, that seemed to have the biggest bucket of that description in the book. Can you talk about, and it's very hot right now. I mean, sorry, that's such an annoying way to talk about it. It's like saying menopause is very hot right now.
It's in the zeitgeist, Vanessa.
It's in the zeitgeist for good reason, because like nobody ever talked about it. I know, it's like, it's so in right now. PCOS is so in right now. What I mean is people are actually talking about something that no one was talking about and so many people were suffering from. Can you describe it for us and explain how and why it's hard to sort of pin it down? The number of bad puns in the last 5 sentences.
And it's you, not me. So I'm liking
everything
everything about what's happening.
I'm going to stop talking, Karen. You talk.
Oh, it's fine. So, and I say in the chapter, I mean, PCOS is really confusing. It is a weird like syndrome condition. It's hard to understand. It's hard for doctors to kind of explain it. So polycystic ovarian syndrome, first of all, the name is a very poorly chosen name because you don't have to have polycystic ovaries to have PCOS. There's a movement to rename it something a little bit more accurate. But anyway,
I would second that.
It's a terrible name. I don't know who came up with this, but so it's not one disease. It's not caused by one gene or one enzyme. It's a group of symptoms. So that's what the syndrome part is. So you only have to have 2 out of 3 things to be called someone with PCOS. One is the polycystic ovaries on ultrasound. And this is, again, where there's a little bit of misinformation. It's not like huge cysts. People think of like giant cysts or bursting cysts. It's not like that. They're actually just teeny tiny follicles. It's just that when you have PCOS, oftentimes you're not ovulating regularly. It's a hormone imbalance. And if you don't ovulate regularly, you have all these little follicles or eggs kind of trying to be released in your ovaries. And you can actually start to see them on ultrasound. They look like a little string of pearls. So that's one criterion. The other is they often cause missing periods. So if you're not ovulating regularly, you're not going to have a period regularly. Ovulation or releasing an egg is the trigger that is, it's like a metronome. It kind of keeps the time of your period. If you don't ovulate, you may skip a period. So sometimes people with PCOS are missing many, many months or even like a year of periods. And then the third is signs of extra testosterone or male hormone. So that can manifest as, people having a lot of acne, facial hair, body hair, and you can actually have normal levels of hormones. So sometimes when we test the testosterone levels, it actually might be normal, but you're still having a lot of the symptoms of it. So it's either symptoms of that or signs of the high testosterone on your lab work. So you only have to have 2 out of those 3 things to be called PCOS. And of course, we make sure it's not something like another condition like a thyroid problem or, like a tumor, like adrenal problem. So, if you have those things, we call it PCOS. It's the most common endocrine or hormone condition in reproductive age women, that's why it's so wild that most people have never heard of it or don't really know what it is. It's more, about the same percent of the population, I think, is like diabetes, and more common than thyroid issues. So it is very, very common. It's at least 10% of women, people assigned female at birth who have PCOS. And it can cause a lot of problems too. It's not just a hormone imbalance. It's also associated with other medical conditions like high cholesterol and diabetes. Actually, most people with PCOS will have insulin resistance or prediabetes or diabetes itself. So it's something about, like hormones and metabolic conditions. It affects like, your cholesterol, your weight, your skin, fertility. It can make it difficult to get pregnant if you're not ovulating. So all of these aspects of life, almost everything in your life. So it's a very, very complex condition. And, therefore it's actually on the more challenging side to fully manage because there's so many different things that could be going on, skin issues, fertility issues, weight issues, all of that.
Karen, one of the things we talk about a lot on the podcast is peripheral fat conversion. And we talk about, in particular, when people carry extra body weight, that they have an enzymatic conversion in their peripheral fat, where they become more estrogenized, right? The sex hormones shift towards estrogen. And PCOS, one of the criteria is a higher testosterone level. And I'm wondering if we see lower rates of PCOS among people who carry more weight or have more body fat because they're converting some of that testosterone into estrogen, or if their hormonostat, which is my favorite word, is so out of whack that it doesn't really matter.
Yeah, it doesn't really matter. It's interesting because, when we think of PCOS, like when people first think of it, they probably think of someone who's overweight or obese. It is something to do with just, again, like you're like, I don't know what the catchy phrase would be, but like, your body's kind of like homeostasis for weight and hormone balance is just off in a lot of ways. And part of it we think is because of the insulin resistance. People tend to have this higher insulin level that makes them hold on to weight. That also affects like their ovulation and everything. So we think something has to do with like the insulin, probably. The problem with the estrogen is a big one too, because sometimes if you are skipping periods, you have this higher estrogen, that actually makes more tissue inside your uterus. So that if you're not having a period, you're building up all this extra tissue. And when you finally bleed, it can be horrible. People bleed for like a month, like with PCOS. When they finally have a period, they're bleeding constantly, tons of bleeding, really heavy. And it's a risk for uterine cancer. The higher estrogen is a risk for uterine cancer, plus you're not shedding it on a regular basis. So all of those things are super important. But what's interesting is that, it actually, people can have PCOS if they're really slim, if they are overweight, every body type. So I actually think it's probably going to end up being more than one condition. I think that because there's so many different ways it can present, like, that probably it's not one thing. It's just been kind of grouped as one thing. Because again, we don't know research.
I agree with you. That's
I completely believe that. I do think that eventually when we know more, it's going to be like 3 or 4 different conditions that manifest differently in different body types and different, like regions of the world, all of that.
Karen, I want to close with an optimistic question, which is if somebody said to you, I'm going to give you a huge grant and you can study one of these gynecologic conditions and you can do the research and
oh God,
we're going to give you a chance to figure this out. What would you choose to study?
Oh my God, that's so hard. I feel like it's like choosing a child, right? Like, which child do you love the most?
Me. Sorry, fibroids. You're not the favorite child.
But I will say before I even answer the question, so Melinda Gates publishes with the same publisher that I do. And she had the same editor as me for a while. And I was just like, please give her a copy of the book. And, because she's got just the whole empire, like it's not like she answers her own emails. So, even if we had the shared editor, like we weren't able to get her a copy of the book somehow, but I was like, come on, Melinda. Melinda's got billions of dollars that she just announced that she's going to be dedicating to women's health research. And I was just like, please.
So for Melinda Gates.
Now.
Yes.
Making the plug. Anybody out there? You're for the Gates Foundation. No,
she's actually, I think Karen's dream come true.
Please. It's not even just my dreams, like just to know all of this stuff and see all the problems out there where you can kind of devote the research funding. So anyway, I know someone out there probably has some connection with Melinda Gates. Please tell her about the book and tell her that there's a lot that we can dedicate the research funding to. And again, obviously, in an ideal world, we would give the funding to all of the women's health problems or the gynecologic problems. But I would actually say fibroids because it affects so many people. It has been historically actually like less, funding and less research than endometriosis, than, menopause, like all these things. And it just doesn't get a lot of press, so to speak. I think, endometriosis, a lot of celebrities have come out recently. Right. And again, I do think that endometriosis needs way more research too. It's not that it doesn't need research, but I think that fibroids, it needs more attention. I think also that racial component of, what do we think is important or what's getting the attention right now? I do feel like we need to put a little bit more effort behind fibroids, just because it hasn't been as buzzy as, PCOS or endometriosis. So.
We're going to make it happen, Karen.
Yay.
I'm willing it into reality. You are amazing. If people listening, you should follow Karen on social media. She's science-based, so funny, does not mess around. And It's Not Hysteria is really, it's like a Bible. And so please read it. You will go back to it again and again. And Karen, I hope you will come back and visit us again.
Of course. I was going to say, there's so much to cover. Like, definitely have me on again. I would love to chat. You guys are great.
We're your favorite, but okay.
Oh, you are. It's like, choosing a child. No, I'm just kidding. But no, definitely have me back on because there's so many things we can cover.
I'm going to make a colposcopy joke now and say we've only scratched the surface, Karen.
Oh, Vanessa. Vanessa and I have now fully swapped He has
Sorry, not
become
sorry.
me.
It's like the family
Yes.
comedy genes. He's like, you gotta like let him loose. That's great.
Oh.
No,
I mean, if my
okay.
brother knows what a colposcopy is, I will sign over my entire net worth now because I do. He's a smart guy, but that I do not think he knows.
That's pretty funny. But we want everyone to know. So after this, everybody, man, woman, child, everybody, we're going to get
After
this
your
information
book,
out there.
Everybody's going to know. Karen, come back. It was so great to have you. And,
I love you guys. Thank you. This is super
wishing
fun.
you much success with the Melinda Gates effort.
It's going to happen. Melinda, we're coming for you. Thank you, guys.
Thanks, Karen. Thank you so much for listening. You can email us with questions, feedback, or episode requests at podcast@lessawkward.com.
If you want to learn more about what we do to make this whole stage of life less awkward for everyone involved, our parent membership, our school health ed curriculum, our keynote talks, and more are all at lessawkward.com.
And if you want products that make puberty so much more comfortable, visit myumla.com.